everybody, this is Mrs. McDaniels, and this is going to be a review over hypertension. And again, like I said, you need to focus on your role as the nurse. So make sure you understand what is blood pressure. Remember that it's the force against the walls of the blood vessels that is caused by the pumping action of the heart. So really, what does those measurements mean? So your systolic, which is the top number, is going to talk about the force during when the heart actually beats, versus the diastolic, and this is the force between heartbeats. So that's going to be when the heart is at rest. So when we're looking at what regulates the blood pressure, we have arterial baroreceptors that helps control blood pressure by altering the heart rate. It can cause vasoconstriction or dilation. Also, your body fluid volume, which relies heavily on kidney function, will also dictate blood pressure. The RAS system, in terms of the process of renin that's released, that turns into angiotensin II, causes constriction and aldosterone release, which therefore makes the kidneys reabsorb sodium and inhibit fluid loss. So when this process is going on, this is going to increase blood pressure. Also, there are vascular autoregulation that helps to maintain tissue perfusion levels. This is the AHA guidelines, what you need to understand. There's a couple of different measurements for testing purposes and what ATI uses. I want you to focus on this next slide, which is the JNC guidelines. So when we're looking at this, optimal is going to be blood pressures less than 120/80. This is considered normal. Your pre-hypertensive range is going to be measurements that are anywhere between systolic of 120 all the way up to 139, with your diastolic anywhere from 80 to 89. This is considered pre-hypertensive. Now, any value that is equal to or greater than 140/90, this is going to be considered hypertensive. And then it breaks down further into what stages of hypertension. So for testing purposes, life purposes, basically anything that is equal to or greater than 140/90 is considered hypertensive or hypertension. Which some of you got a little confused on that and wanted to say it was values greater than 120/80, which, as you can see here, puts the person in a pre-hypertensive category. So some tips about taking blood pressure: you want to make sure that the cuff is on correctly and that you use the correct size cuff. Don't place over clothes. Don't place the cuff upside down. This is taken back from your fundamentals book, so if you need to, go back to your fundamentals and review this. If patients are in an outpatient setting, put them in a seated position. Inpatient, lying in bed or seated position. If a person is seated, make sure their arm is at the level of the heart. No talking or movement from the patient. Make sure that they don't cross their legs. Make sure that they don't need to go to the bathroom. Again, legs need to be kept uncrossed. And most importantly, if the systolic is greater than 160 or less than 90, and the diastolic blood pressure is greater than 100, then you need to retake and ensure you're getting a true reading. Since a lot of times we use the electronic blood pressure cuffs in the hospital, make sure that you retake it. I would also suggest using a manual if possible, for reliability purposes. And make sure too, if you're going to do that, you need to allow some time in between the measurements, 10-15 minutes. You don't want to do it right away. There are different types of hypertension. You have essential hypertension, which is considered primary hypertension. This accounts for most cases. There's really not always a known cause. Secondary is going to be a result of something else. So it could be a medical condition, adverse effect from some medications, and sometimes simply the treatment is removing the cause. People who are pre-hypertensive, and again that falls in that systolic blood pressure range of greater of 120 to 139, and diastolic blood pressure greater than 80 to 89. A lot of times the treatment, first step is going to be lifestyle changes. It's going to be modifying diet and exercise. Some other types of hypertension, you may hear white coat syndrome. This is when patients claim that their blood pressure is normal when at home and it becomes elevated in the clinical setting. The reverse of that is called masked hypertension. This is when the blood pressure appears normal in the clinical setting, but patients make complaints that it is elevated at home. Now, when we look at hypertensive crisis, it really is an umbrella for two different types of crises. One's either urgency or an emergency. So on your quiz that you had, I listed just clearly hypertensive crisis. I should have got a little bit more specific, so I basically accepted true or false for that question simply because it really relies a little bit heavier on what the diastolic is. So an urgency is elevated, but at that point in time there's no impending target organ damage, and patients can have headaches, nosebleeds, and anxiety. The goal really is to get the blood pressure down to 160 over 110, and it can typically occur with outpatient management. Once that diastolic is getting 2 or greater than 120, it does typically go along with target organ damage. You want to reduce the blood pressure, but not to do it quickly, usually by 25% over 2 to 6 hour period. The exception is going to be if a person is having aortic dissection, you want to get and keep the blood pressure low. Other issues, signs and symptoms and treatments for hypertensive crisis. And a lot of times this may occur in patients who do not follow medication therapy, or they might have undiagnosed or untreated hypertension. So severe headache, extremely high blood pressure, blurred vision, dizziness or disorientation, and epistasis, which is a nosebleed. Treatment, initially they'll use IV antihypertensive therapies. Before and during after, you need to monitor their blood pressure every 5 to 15 minutes. You need to assess the patient's neurological status, looking at their pupils, level of consciousness, and muscle strength, and to watch for any cerebral vascular changes. Also watch their EKG to assess their cardiac status as well. So some of the problems with hypertension is that it's going to put a patient at a greater risk for stroke, heart failure, sexual dysfunctions, kidney disease and failure, heart attack, and vision loss. To go a little bit more in depth about that, target organ damage with hypertension in terms of the vasculature, there's atherosclerosis, aneurysms, and aortic dissections here, where when we're talking about the heart, we can have pulmonary edema, myocardial infarction, which is MI or heart attack, left ventricular hypertrophy. In terms of our kidneys, hematuria, uremia, and proteinuria. That is basically showing some damage to the kidneys. The brain can have hemorrhaging, infarction, strokes, seizures, and vascular dementia. Eyes, again, we're talking about the small vasculature, so hemorrhaging, exudates, something called AV, nipping, and papilloedema. Lab values, as you're going through and preparing to study, make sure you have a good, clear list of the different labs that you should be familiar with. So in terms of determining secondary hypertension and target organ damage, kidney disease, we're going to look at the BUN, creatinine, urine analysis, elevated uric acid for essential hypertension. Cushing's disease, you will want to look at elevated serum corticoids and blood vessel changes. Especially for diabetics, look at their A1C and cholesterol studies. So total cholesterol, HDLs, LDLs, and your triglycerides. Diagnostically, to look at cardiac function, we can do an ECG. If we're looking for left ventricular hypertrophy, and that's the thickening, you're going to see tall R waves on an ECG. You can also see that thickened muscle on an echo. And to look for cardiomegaly or an enlarged heart, we can see that on a chest x-ray. So some risk factors for essential hypertension, mnemonics, SADIC, sodium and fat intake, obesity, oral contraceptives, smoking, stress, alcohol, African Americans, age can determine as we age, vitamin D deficiency, inactivity, and caffeine and cholesterol levels. Secondary hypertension, we can put it as ABC DEP, is aldosterone, a bad kidney, catecholamines, Cushing's disease, drugs, hormones in terms of the endocrine, phenochromocystoma, if you remember that, which is a tumor of the adrenal glands, and pregnancy as well. So some things we have to think about with the aging patient. As we age, hypertension risks do increase. Structural and functional changes of the heart will impact how it can actually function. When there is structural changes, there's also an increase in stiffness of the walls, which basically makes it difficult for the heart to kind of buffer that pressure. And so when there's less elasticity to the arteries, you're going to have greater pressure, have a higher blood pressure. Pulse pressure of 50 millimeters per mercury or more is associated with the increase intracranial pressure, atherosclerosis, aortic insufficiency, and fever. If medicine is needed for these patients, you should always go slow. Start low and go slow. And you want to make sure that you talk to a patient about the effects that they may feel when they first start an antihypertensive regimen. Also teach safety, and that includes positional changes and using supportive devices for walking. Hypertension, unfortunately, is also known as a silent killer. I think I said before, diabetes is a silent killer. I guess there's a lot of things that can happen to you that can kill you silently. Those who are hypertensive sometimes, unfortunately, may have no or few symptoms until crisis happens. So educate patients to watch for headaches, especially those in the morning. Sometimes those are indicative of hypertensive crisis. Facial flushing, dizziness, fainting, retinal changes, visual disturbances, nocturia, and nosebleeds, which again could be indicative of a hypertensive crisis. So health promotion and disease prevention. Things that you need to talk to your patient about, BMIs of less than 30, you need to encourage them to increase their activity level. Blood glucose levels should be checked regularly, especially in your diabetics. Those who are diabetic should try to be well controlled of an A1C less than 7. Limit caffeine and alcohol. Talk to patients about stress management. Sometimes simply a change in a job can help decrease stress. Stop smoking. Aerobic exercise at least 3 times a week, and limit their sodium and fat intake. And that goes along again with the diet. So hypertension and smoking. Smoking does not cause hypertension. A person with hypertension who smokes increases the risk from dying of heart disease. Pharmacological management. Again, monitor potassium levels when we're talking about diuretics. Diuretics typically are first line for managing hypertension. What can happen sometimes, patient X walks in, sees a doctor, they have elevated blood pressure, doctor has a conversation with the said patient, says, hey, why don't you exercise, lose some weight, come back, and we'll check your blood pressure again, see if there's any improvement. If things don't change with diet and exercise, the first line is going to be the use of a diuretic. And typically it's a thiazide diuretic, HCTZ, which is not potassium sparing. So you're going to want to educate the patient about eating foods that are going to be rich in potassium. Loop diuretics, furosemide, is another one that is used. Spironolactone, which is a potassium sparing diuretic, may be used, but typically those patients are going to be at the opposite, a risk for hyperkalemia. However, a lot of times we just don't see patients on a diuretic. Even though diuretics are first line, you'll see a lot of patients with a combination with another antihypertensive medication. For example, the big most common one is lisinopril HCTZ, which lisinopril is your antihypertensive medication in combination with a diuretic, which is HCTZ, which is a thiazide diuretic. Calcium channel blockers, verapamil, amlodipine. I just can't spit it out at this time. I think you guys have been catching on that I have a very difficult time saying medications. Amlodipine. I think the longer I look at the word, the worse it gets. But that those work by altering the movement of calcium ions through the cell membrane, causing vasodilation, and therefore lowering blood pressure. It also helps with afterload and workload. With all antihypertensives, when patients start, you need to talk to them about changing their position slowly, dangling their feet over the side of the bed. Other educations that they may want to watch is to avoid grapefruit juice. It potentiates the medication's effects, and you need to, and it can also lead to medication toxicity. So with most antihypertensives, patients should avoid grapefruit juice. And in fact, most hospitals just do not allow grapefruits or grapefruit juice allowed in the hospital because it seems to be one of the things that can actually interfere with a lot of different medications. Beta blockers, those ending in LOL, cause vasodilation. It will decrease cardiac output and heart rate by blocking the beta and adrenergic receptors of the sympathetic nervous system. Some side effects: hypertension, bradycardia, fatigue, weakness, and heart failure. Your ACE inhibitors, your PRILs. Two big things: talk to a patient about a cough and angioedema. Angioedema is rare but life-threatening. Patients typically, even if they have a cough, it is bothersome and it affects compliance. So if a patient develops a cough, they should contact their provider and be switched to a different medication. So even though the cough doesn't seem to be like a big deal, it is bothersome and interferes with compliance. Your ARBs, the big thing you need to know about ARBs is that there is a contraindication of its use in pregnancy. And I won't really test you at all on the aldosterone receptor antagonists. Medications that are in the category of central alpha agonists like clonidine, they help decrease peripheral resistance and blood pressure by actually preventing the reuptake of norepinephrine. Big thing with this type of medication is some off-label uses is for insomnia, because no matter how many times you take it, it does make a person extremely tired and sluggish. And so even when they are used for off-label purposes, blood pressure should be monitored. And you won't have any questions on alpha algineric antagonists for me. So some patient teaching about antihypertensive medications: they should be instructed to change position slowly, be careful when getting out of bed, when driving, climbing stairs, until they actually know how the medication is affecting them. Patients should be taught to report manifestations of electrolyte disturbances, stress the importance of compliance, give them verbal and written instructions about any new medication, make sure that they're able to obtain their medication, that they continue regular checkups, and know that old patients are more susceptible to orthostatic hypertension and other effects, so you need to do more education with these patients. And talk to them about lifestyle changes that may be needed that can actually help enhance the effectiveness of the antihypertensive medications, like lifestyle changes and or diet. So again, we're talking about patients about diet. DASH diet promotes more fruits, vegetables, whole grains, limits salt, and also promote low-fat dairy. Have foods that are high in potassium. Salt substitutes are actually high in potassium, and we went into a very long discussion about salt substitutes. They taste like salt, but they're actually not sodium and high in potassium, unlike some other seasonings like Mrs. Dash, which is just a variety of spices to replace salt. And also how to read nutrition labels as well, because sizings and portions can be very deceiving. Patients should try to get some exercise at least 3 times a week. Begin slow, advance as advised. Reduce stress. Stress is bad for the heart. And that could be anything from knowing what the triggers are, deep breathing, meditation, taking some time for yourself, relax, active lifestyle, and quit smoking. So that's about it on hypertension. Please make sure that some of the points that I emphasize, that you pay attention to those, and I think you should do just fine.